what's up? This is Kylie with Punks for Progress. I'm going to be making some videos for you guys, basically just about things I come across in the media, and then what I go on to research about it on my own, and have a better understanding about it. Hopefully package up that information, simplify it, and pass it on to you. So this first video is about healthcare, our current healthcare system. Try to simplify it for you, and again, this is stuff that I've just recently been able to understand and verbalize. So if I get some things wrong, sorry, correct me, please share your info, share videos. We all got to figure this out together. So here we go. So first of all, let me tell you that I'm a nurse. I work on the inpatient side of things in a hospital. So I interact with and see a lot of administrative issues. I see a lot of protocol changes. I see supply changes, medication changes. I see doctor-patient interactions. I see patient diagnoses. I see the whole slew of tests that are performed for patients. So in future videos, I hope to add, my perspective, from that perspective on things. However, for this video, I'm going to be clearly speaking as a patient, on the outside of things, someone who interacts with the healthcare system as a customer, someone who goes to the doctor's office, goes to the emergency room, gets prescriptions filled, and gets the bill a few months later in the mail and is pissed off because I have no idea how they came up with this number that I'm supposed to pay out of pocket for services that I thought were routine, but actually turned out to be very, very expensive. So anyway, I want to start off by breaking down the healthcare system into 4 different entities, and we'll separate them and how they interact with each other. And if you already know this, good for you. I've been a nurse for 4 years, and I still couldn't verbalize any of this until recently. So the first entity is health systems, and these are the companies that run the hospitals. They are the brand names on the outside of the hospital. In your area, you could probably name the 3 or 4 hospital chains that are around that you could choose from, supposedly, to go to. In Northern California, where I've worked and where there's an issue we're going to talk about in a little bit, there's Sutter Health Systems, there's Kaiser Hospitals, there's John Muir Medical System, there's Dignity Health. Where I'm at right now in Virginia, there's Carilion. There's a different health system called Lewis Gale. So you could probably, again, identify what's in your own area as the health system. That is the same brand on the outside of the hospital, that's on the outside of the doctor's office, that's on the outside of the pharmacy even. And that's the umbrella, and they share the same umbrella company. Entity 2 is insurance companies, the liaison basically between the client and the provider. And then an offshoot of that, I think that belongs in the same entity, is the government-run insurance companies, Medicare, Medicaid, and the VA, which interact very differently with hospitals. Entity 3 is the employer. So if anyone has an answer to this, please let me know. Why do we get our insurance through our employer? Why is it set up that way? I feel like that puts way too many limitations and way too many other interests above the health of the individual. Anyway, from what I've gathered, sometime in the 1950s, a group of teachers got together and demanded that they get a group rate through their employer for insurance. And I guess that's just been what we do since. And this is if you are fortunate enough to have a job, A, and B, have a job that offers insurance, which is not the majority of America. So anyway, but And that's how I'm going to explain it. Entity 4 is the individual. It's you, it's me. We are the ones that go to the hospital, that get the procedure done, that go home, and 3 months later get a bill in the mail. After that procedure has gone through a maze, an administrative maze, and pooped out this number that we're supposed to pay out of pocket. So yeah, the fourth entity is individuals. Health systems, insurance plans, health systems, insurance companies, employers, individuals. So finally, let's talk about an article that came out last week that sent me down this rabbit hole. And it highlights something going on in California right now, but I believe it's a practice going on across the United States. And that is that these health systems are getting bigger. They're acquiring more hospitals. They're buying out the rural hospitals and slapping their logo on the outside of the building. And in doing so, they are able to dominate the market in that area and create a monopoly. Some synonyms with monopolies are antitrust and anti-competitive business practices. These are things I've come across in my research I want to pass on to you. So the Attorney General in California is suing Sutter Health, a health system in Northern California, for doing this, for raising prices because they have a monopoly over the area. Something I personally find interesting, having lived in Northern California, Sutter Health, I guess, is a big health system, but there's plenty of other huge health systems in the area, and I wonder why Sutter is getting sued over the other ones. They make it out that Sutter's this huge health system. It has 24 hospitals, and it's taking over. But one step down is Kaiser, and they have 23 hospitals, and the next step down is Dignity Health, and they're somewhere in the 20s. So these are huge health systems anyway. So I'm not quite sure what's going on with Sutter, but Sutter is being sued right now. Now, in response, Sutter has claimed they are not price hiking, that they are just keeping up with the market in Northern California. And so what they've done is they've requested or subpoenaed all the other area hospitals and the area health systems to release their prices for procedures so that they can show and prove that, hey, it's just comparable to what the prices are in this area. Fair enough. Good strategy, I guess. If you're being accused of overcharging, tell everyone to go to the other stores and they'll see that prices are the same. In response, all the other area hospitals have said, no, absolutely not, no way, we are not making public and not even going to share with your lawyers or anybody's lawyers what our prices are. And that is the spotlight for me on this article, and the light it sheds on this practice of prices being negotiated between hospitals and insurance companies who both have their best interests in mind and not ours, who are both trying to save money and make money and basically wine and dine each other for the best prices. So let me read a piece of the article. This article came out a week ago in the San Francisco Chronicle, and again, I just want to read that paragraph that concisely explains this spotlight on an issue, I think, in healthcare. Hospitals make money by charging insurance companies and government insurance programs, Medicare and Medicaid, for providing medical services. Each hospital negotiates rates with each insurance company, agreeing on many different prices for specific procedures and services. Keeping the rates confidential benefits both the hospital and the insurance company because it prevents the other side from knowing about and demanding that they match a better deal they gave a competitor. But it also prevents customers and policymakers from being privy to the data and is one of the main reasons patients often don't know how much a certain medical procedure will cost. So basically, there's contracts between hospitals and insurance companies. And Hospital A could work with 8 different insurance companies and have different set prices for a simple x-ray for all 8 different insurance companies. I think that's really gross. So because none of these prices are public, I can only imagine, I mean, the sky is the limit as to how integrated these contracts are with the number of procedures, if there's quotas, if there's incentives for certain diagnoses or certain tests or procedures or certain medications being prescribed. I feel like it leaves a lot of room for diagnoses and tests to be manipulated in the best interest of the hospital and the insurance company.
Hold my hand, it's shaking bad, I'm going to the doctor. I pay him, he'll fix me up, I think I got enough. No ambulance, no cost too much. We'll take a van. If they can't fix me, no one can. If they can fix it, no one can. Want you to take me to the H, take me to the O. Want you to take me to the S, take me to the P. Want you to take me to the I, T, and L. Want you to take me to the hospital.
So let me run through a real life example. A few months ago, recently I required stitches in my ankle. I didn't want to get stitches, but the bleeding wouldn't stop after 18 hours. So I go to the emergency room. Now there's no way for me to Google which emergency room was going to be cheaper. Again, those prices aren't available to us, and they're not set in stone. They're based on different contracts that the hospitals have with, and that the health systems have with different insurance companies. So I go to the hospital, and the people working on me, the nurses taking my blood pressure, the doctors sewing me together, the aides who are going to be, and the workers who are going to be cleaning up after the mess, none of them know how much this is going to cost. And as I'm sitting there saying, how much is this going to cost? Oh my God, they don't know. And they don't care. And that's probably a good thing. Who does know is the liaisons between the hospitals and the insurance companies, and nobody else knows. This is why that's why you can't show up to a doctor's office and say, oh, how much is my heart surgery going to cost? It's going to be based on so many factors. So I go and get my stitches. 10 stitches, I required 30 packs of gauze, and it was 25 minutes face-to-face with the doctor, him providing a specific service to me to stitch up my wound. So that gets coded and billed over to the insurance company. Those three things, that I required 25 minutes with the doctor, I required 10 stitches, and I required 30 packs of gauze. So again, hopefully you're catching on. The rate that the insurance company, so the price of those three things is specific to what contract my insurance company has with that hospital. And if I had chosen a different hospital, it would be a completely different price. And if I had a different insurance provider, it would be a completely different price because they have different contracts. Again, I can only imagine they have quotas and incentives, and it differs all across the board. And thus begins the journey of this administrative maze of the price that gets pooped out at the end that I have to pay out of pocket. Basically going through this contract that my insurance company has with this specific hospital, and then going over to the group rate that my employer has with this insurance company, and then specifically what plan I have set up, and the specifics of that plan, and how much of each of those things is going to be covered or not. And then, like I said, then I get a bill in the mail 3 months later as to what I have to pay. So let's talk about outliers to that algorithm. And that first thing I want to talk about is the uninsured. Those who don't have insurance, A, by choice, B, by no fault of their own, C, by being excluded because of their conditions, situations. They may be employed, but their employer doesn't provide insurance. These situations. So these people, unfortunately, do not get the health maintenance that they need. They don't have affordable intermediate care where they can go to clinics or go to their doctor's office or go to see specialists on an outpatient setting to get, again, the health maintenance they need for certain diagnoses. So they are more likely to present to an emergency department with extremely urgent needs because they've put off health maintenance because of the price. And what hospitals are claiming is they have to raise the price for procedures for people who are insured to cover the cost of those who are not insured. And I think that was a big talking point with Obamacare, is that let's increase the pool, let's get everybody paying premiums, so we're not getting overcharged for those that don't have insurance. I'm sure at your dinner tables, at Thanksgiving dinner, why are we paying for the uninsured situation? And I'm sure we could talk a lot about that. But that's one outlier. The next outlier is Medicare, Medicaid, and the VA. So they basically take the place of that private insurance company and that second entity to contract with hospitals. Now, the thing about Medicare, Medicaid, and the VA is they're government run. And because of this, they do have set prices, and those prices are made public and are standard. And also because they're government run, they can be manipulated where the hospital does not get reimbursed if those procedures were not effective, if the medications were not effective. And I think this was a big thing with Obamacare also, is that insurance companies that I know Medicare and Medicaid and the VA, and I think that's now moved on to also insurance companies, they do not have to reimburse if the service was not deemed A, appropriate, or B, successful. I know as an inpatient, as a nurse, there's always a flag on someone's chart if they've been readmitted within 30 days. Because it's very likely the hospital will not get reimbursed for any services from that previous admission because it was not deemed successful. They had to come back to the hospital within 30 days. Well, what did we miss in that first visit that could have prevented the next hospital visit? Now, I'm still on my journey of understanding that better, and so I'm open to suggestions. I'm open to education and your own experiences about what has changed with the Affordable Care Act. Has it been better? Has it been worse? Who is it benefiting, profiting, etc.? So I spent this whole video talking about what we currently have. But I do this in hopes of having future conversations, and please comment below, how do we make this better? What piece of the system needs to go? How do we change it completely? What do we do with the uninsured? Why do we stigmatize them? How have we come to where we've got, if anyone has an answer about why we get our insurance through our employer, please tell me. I'd really appreciate it. So anyway, going forward, I know I want to continue having a discussion. Punks for Progress in general, we are looking for better solutions. We want your input. What has got to change? What is going to make it better? Is it completely gutting the system? Is it going with a single payer, which basically means expanding Medicare so that those prices are set and public and regulations can be imposed on hospitals? Please share your comments. So there it is. It's the video about our current healthcare system. It's an invitation to continue this discussion about how do we make it better. But what I want to leave with is that I think this whole thing is disgusting. I think that we're talking about people's health. We're talking about people's lives. We're talking about diagnoses that do not discriminate. Sure, there's some factors that attribute to some diagnoses. But I can tell you a stroke can happen at any time, at any place. A heart attack can happen at any time, any place. A cancer diagnosis can happen at any time, in any place. So do not think that you're immune or anybody else is immune. Everyone needs access to the best healthcare. Everyone deserves access to the latest developments, the latest research, the most expensive drugs. The fact that there's gates keeping people out based on money and contracts and business deals is really disgusting. I think that health is even more, it should be valued over money, but it's not. And if you've personally experienced that, I'm sorry. And I hope that we can change. I hope that our society can change, that we value health more than money. All right, thanks for listening, and we'll chat soon.